Right, so we have already discussed what are alpha 1 action and what are alpha 2 action, right? Now we'll talk about beta 1 action and beta 2 action. Beta 1 action means the typical action produced in our body when beta 1 adrenergic receptors are stimulated. When I mention in future that there are beta 2 action, actually I mean that what are the typical actions produced in our body by stimulation of beta 2 adrenergic receptors. So let's first talk about typical beta 1 action. You must be knowing that beta 1 receptors are distributed in three important tissues. What are those tissues on which beta 1 receptors are present? Yes, please. Number one is your heart. Your heart has beta 1 receptors. In the heart, you know, there is SA node, there is AV node here, bundle of His and Purkinje system. Now, beta 1 adrenergic receptors are present on, yes, SA node, they are present on atrial myocardium, they are present on ventricular myocardium, as well as beta 1 receptors are present on AV node, and they are also present on special conduction system. Right? It means beta 1 receptors in the heart are distributed most of the areas. Why I am specially stressing that there is a good beta 1 adrenergic receptor distribution, because when we talk about cholinergic muscarinic receptor distribution, that is different. You know, as vagus nerve releases acetylcholine on the heart, and cholinergic muscarinic receptors are not distributed on all the heart. Cholinergic receptors are distributed mainly on SA node and AV node, little on atria, and not on ventricles. So cholinergic action mainly affect the SA nodal activity and AV nodal activity, but adrenergic action affect SA nodal activity, AV nodal activity, also affect the atrial and ventricular contraction. Is that right? Now, let's suppose if you have a drug which can stimulate beta 1 receptors. Can you tell me a drug which can stimulate beta 1 receptors? Yes, please. There are so many intelligent doctors sitting here. Yes, this any drug, single drug which can stimulate beta 1 receptor. Let me tell you, this drug is going to be important because in failing heart, it can stimulate the heart and increase cardiac output. Now, yes, enalapril. I think enalapril was somewhere like angiotensin converting enzyme inhibitors, right? It is still, yes. Digoxin. Remember, this answer is wrong. Digoxin is not adrenergic drug. Digoxin basically stimulate vagus nerve to release more acetylcholine. Plus, digoxin can block the sodium-potassium ATPases in the myocardium, so that less sodium goes out of the myocardial cell. And when sodium accumulates into myocardial cell, intracellular sodium is exchanged with extracellular calcium. And then calcium comes in and increases myocardial contractility. That is the mechanism of action of digoxin. That has nothing to do with the beta 1 adrenergic receptor stimulation. Any drug which can stimulate beta 1 adrenergic receptors. Yes, Gavin? Okay, he comes with a perfectly wrong answer. He says atenolol. Atenolol is beta 1 blocker. My friend, I'm asking about beta 1 stimulant. You know, yeah, dopamine and dobutamine. Dopamine and dobutamine, they have a beta 1 stimulant action. We'll talk in detail later when we'll talk these drugs into detail. But for a while, you must know dopamine and dobutamine. These are beta 1 stimulant, right? Especially dopamine is cardiostimulant with renovascular dilator. Dopamine stimulates the heart and dilate the renal vessels and improve renal blood flow. Dobutamine mainly stimulates the heart. Okay, it's a little out of the way, but it's worth talking about. If you come across a patient where heart kinetic activity is slow, heart is pumping very poorly, cardiac output is very low, and due to low cardiac output, renal blood flow is also less. For example, a patient who is undergoing shock, a patient who is undergoing shock, circulatory shock due to cardiac failure, and heart is not pumping well, right? And of course, when heart is not pumping well, cardiac output to brain is also less and sympathetic overflow occur and renal vessels constrict. And if renal vessels constrict intensely, that may produce the risk for acute tubular necrosis. So when you have a patient with a combination problem, a patient with reduced cardiac output with renal vasoconstriction and threat of acute tubular necrosis, the drug of choice to stimulate the heart is dopamine, because dopamine has beta 1 stimulant action, plus it stimulates dopamine receptor on renal vasculature to dilate the renal vasculature. So dopamine is a wonderful drug, even though it has to be given by intravenous infusion, that it can, by beta 1 action, it can stimulate the heart and increase cardiac output, and simultaneously it can dilate the renal vessels and reduce the risk of acute tubular necrosis. But if you come across another patient, his main problem is reduced cardiac output due to reduced contractility of the heart, but renal blood flow is not significantly reduced, that patient should not be given dopamine, because you don't need renal dilation there. Again, the patient, second patient, which has main problem with the reduced cardiac output due to hypokinetic heart which is poorly contracting, right? But renal blood flow is acceptable. You want a drug which specifically stimulates the beta 1 receptors, then drug is not dopamine, drug is dobutamine. This is the real basic difference in these two drugs, other than the spellings, right? Dobutamine is cardioselective stimulation, and dopamine is cardiostimulant plus renodilator. Okay, let's come back. We were talking about the beta 1 adrenergic actions in your body, the typical beta 1 action. If you forget everything, please remember cardiostimulation. Whenever we say beta 1 stimulation, cardiostimulation. Whenever we say beta 1 blocker, cardio inhibition. Is that right? No problem? And of course, you know that when adrenergic drugs will stimulate the SA node, adrenergic agonist, beta 1 stimulant, when they will stimulate the SA node, there will be increased chronotropy. And if beta 1 drug, beta 1 stimulant, stimulate the AV node, yes, what is that? When AV node is stimulated, yes, when there is AV node stimulation by beta 1 adrenergic drugs and conduction through AV node become more positive, dromotropy. And when beta 1 receptors on, yes, specialized conduction system are stimulated, and excitability, yes, electrical excitability of Purkinje system increases, and specialized conduction system has increased excitability when there is more norepinephrine or epinephrine stimulation on beta 1 receptor. What we call it? Positive? Don't tell me positive inotropy. It is positive bathmotropic. Positive bathmotropic. It has nothing to do with bathroom. Bathmotropy. Yes, I must remind. Because once I ask a student, what is positive bathmotropy? You say when in the washroom you release a lot of adrenaline and your heart rate becomes fast. Right? There are people like that, don't worry. So remember, positive bathmotropy means there is increased excitability of specialized conduction system. Is that right? And when SA node is excited, that is positive chronotropy. Bathmotropy, it is important to know, because overexcitation of specialized conduction system by the epinephrine and norepinephrine produces arrhythmia risk, tachyarrhythmia risk. When there is overstimulation of specialized conduction system by adrenergic beta 1 stimulation, that may increase the risk of tachyarrhythmias. Then beta 1 receptors are of course present on the contractile myocardium. So when Beta 1 receptors are stimulated on the, yes, atrial myocardium and ventricular myocardium, and degree of myocardial contractility is increased. Degree of myocardial contractility is increased. This is called positive inotropic. Now I think there is something here I need to explain more clearly. Look, let's suppose on this there is contraction, and on this is the time, right? Let's suppose before getting beta 1 stimulation, patient has contraction, myocardial contraction, which goes to the peak and then come to the relaxation, right? You know, during the systole, left ventricle contract. So this is systole, and left ventricle start contracting, pressure goes to the peak, myocardial contraction has gone to the peak, and then myocardium relaxes. Is that right? This is without exogenous beta 1 stimulation. Now let's suppose you give injection of a drug which is beta 1 stimulant. After the injection, this profile will change. After the injection, after the beta 1 stimulation, look at it. Contraction will go like this and this. Now what are the real alteration? Number one, the total degree of contraction has increased, because before the beta 1 stimulation, degree of contraction was up to this. You know this. After the drug, total strength of contraction has been increased. This increase in the strength of contraction, yes, this increase in the strength of contraction is called positive inotropy, right? That strength of contraction has significantly increased. Before, strength of contraction was here, now strength of contraction is there, right? But there is another thing which has increased, you know, velocity of contraction and relaxation. Let me show you how. Look, contraction started from here, and to reach to the peak, it took this much time without beta 1 stimulation, right? Contraction took so much time to reach to the peak. But after the beta 1 stimulation, you see contraction went very rapidly to the peak. Now peak could be achieved only in this time. So it means that without beta 1, heart was contracting slowly and for lesser strength. With beta 1 stimulation, heart contract with high velocity and with higher strength. This increase in velocity, that to reach to the strength, it is taking shorter time. Are you understanding me or not? Right? This is called positive clinotropy. What is that? Positive. This is this thing that heart previously was taking so much time to reach its peak contraction, but in the presence of beta 1 stimulant, it took a much less time to reach to the peak. This effect of beta 1 stimulation is called positive clinotropy. Yes, positive clinotropy. So let me repeat it. If I say beta 1 stimulation produces positive chronotropy, it means the stimulate SA node, pacemaker, normal pacemaker activity. When I say that beta 1 stimulant produce positive dromotropy, it means the increased conduction through AV node. When I say that beta 1 stimulation produce positive bathmotropic, it means it increase excitability, electrical excitability of myocardial cells, right? Especially specialized conduction system. When I say there's positive inotropy, it means there's increased strength of contraction in myocardium. When I say there is positive clinotropy, I mean there is increased velocity of contraction of the myocardium. So actually, beta 1 stimulant are positive inotropic, positive chronotropic, positive dromotropic, positive bathmotropic, positive inotropic, and positive clinotropy. This has clinical significance, because when there is positive chronotropy, there is increased heart rate. Is that right? And when there is positive inotropy and clinotropy, there is increased stroke volume. So it means due to positive chronotropy and due to positive inotropy and clinotropy, right, there is increased heart rate plus there is increased stroke volume. It means there is increased cardiac output. It means there is increased systolic blood pressure. So all the drugs which are direct cardiostimulant, which are positive chronotropic and positive inotropic, they increase the cardiac output and they increase the systolic blood pressure. And it's very easy to understand that if there's a drug which is beta 1 blocker, can you tell me any drug which is beta 1 blocker? Like atenolol, metoprolol. So if you give up your patient beta 1 blocker, that will be acting as negative chronotropic, negative dromotropic, negative bathmotropic, negative inotropic, negative clinotropy. And these patients, when heart rate will decrease with beta 1 receptor blocking, and there is decrease in contractility and stroke volume, there will be decrease in cardiac output and there will be decrease in systolic blood pressure. Is that right? So one of the typical action of beta 1 agonist is cardiostimulation. Is that right? And one of the typical action of beta 1 blocker is cardio inhibition. Fine. So this was one thing, that beta 1 receptors are present on myocardium. Then we come to the second tissue on which beta 1 receptors are present abundantly. If you remember previous lecture, you remember that there was, yes, juxtaglomerular apparatus in the kidney, and juxtaglomerular apparatus also has lot of beta 1 receptors. You must be remembering that juxtaglomerular apparatus, right? This is macula densa. Here are your arterial, afferent and efferent arterioles, right? All of this is juxtaglomerular apparatus, right? And juxtaglomerular apparatus is having beta 1 adrenergic receptors. So whenever beta 1 stimulant are present in your body, they stimulate the juxtaglomerular apparatus and increase the release of renin, and renin angiotensin aldosterone axis is stimulated, and then angiotensin 2 mediated. Of course, when renin is more, angiotensinogen is converted into angiotensin 1. Then in the lungs, angiotensin 1 is converted into angiotensin 2, and then angiotensin 2 produce arteriolo. Okay, before I tell you these things, I want to know, ma'am, angiotensin 2 is a stronger vasoconstrictor or epinephrine is a stronger vasoconstrictor? Yes, ma'am, I'm about to be impressed by you. Yes. Okay, yes, sir. Epinephrine is a stronger vasoconstrictor or angiotensin 2 is stronger vasoconstrictor? I don't know, you have to decide. Yes. You think angiotensin 2 is more powerful than epinephrine? Okay, Dr. Sergio Mauri says angiotensin 2 is more powerful than epinephrine and norepinephrine. Anyone who does not agree with him, raise your hand. Yes, many people raise hand. All of you are wrong. Angiotensin 2 is 1,000 times more powerful than epinephrine and norepinephrine on weight basis as a vasoconstrictor. Why? Yes, he knew it. That's good. Yes, he knew it. Yes. And then he must know one more thing. The drugs which slightly reduce angiotensin 2 level significantly control blood pressure. That's the point to be made, right? So, what is happening? Anyone who is beta 1 stimulant, it increase renin angiotensin aldosterone axis, right? But let's suppose if we give a drug which is beta 1 blocker, beta 1 blocker will not only act as cardio inhibitor, but beta 1 blocker drug will block beta 1 receptors on juxtaglomerular apparatus, and renin production in your body will be less. And when renin will become less, then angiotensinogen into angiotensin 1 will be less. And angiotensin 1 converted into angiotensin 2 will be less. Then angiotensin 2 mediated arterioconstriction will be less. Then diastolic blood pressure will be less. Then angiotensin 2 mediated venoconstriction will be less. Venous return will be less. Cardiac and diastolic volume will be less. Cardiac output will be less. And systolic blood pressure will be less. Even aldosterone will be also less. Angiotensin 2 not only constrict arteriole, not only constrict veins, angiotensin 2 also stimulate zona glomerulosa to produce aldosterone. So when angiotensin 2 is less, then aldosterone is less, then aldosterone mediated salt and water retention is less, then blood volume is less. Venous filling is, then blood volume is less, then venous filling is less, then venous return is less, then cardiac filling is less, then cardiac output is less, then systolic blood pressure is less. That is why those drugs which reduce angiotensin 2 level in the body are very, very good antihypertensive drugs. But here we should make a point that beta 1 blocker drugs reduce the blood pressure by cardio inhibition and also reduce the blood pressure by inhibiting the renin angiotensin aldosterone system. Am I clear? Then any other beta 1 actions? Of course on the lipocytes, adipocytes. Your friends adipocyte keep on accumulating in your body so frankly, right? They also have modified beta 1 receptors which are called beta 3 adrenergic receptors. And if there is a drug which can stimulate these adrenergic receptors on lipocyte or adipocyte, that will produce lipolysis. And if you have a drug which can stimulate beta 1 receptors, that will produce lipolysis. Is that right? And if there is a drug which block beta 3 receptors, of course that will prevent lipolysis. Am I clear? So next time if I say there is a drug which beta 1 action, you know it. It's cardiostimulant and it is amplifying production of renin and producing renin angiotensin aldosterone system stimulation and disrupting some lipocyte function. Right, now we come to beta 2 action. Is that right? Now we come to beta 2 actions. What are the typical beta 2 adrenergic receptor mediated actions in your body? Yes, beta 2 receptors. Number 1, in the lungs there are beta 2 receptors present on, yes please, yeah, where they are present? On bronchial smooth muscle. On bronchial smooth muscle there are beta 2 receptors. These are bronchial smooth muscles. It's a very simple diagram, and on this smooth muscle, I bring it out, there are beta 2 adrenergic receptors, right? And beta 2 receptors are inhibitory receptors here. So when there is beta 2 stimulant, right, this will inhibit the contraction of bronchial smooth muscles, right, and that will end up into what? Beta 2 mediated bronchodilation. And this is clinically a very important concept. That when beta 2 receptors on bronchial smooth muscles are stimulated, that leads to beta 2 mediated bronchodilation. Yes. Pharmacologically, we take advantage of this mechanism in patients with asthma. Patients who have generalized tendency, patients who have a tendency for generalized bronchoconstriction, like patient with asthma. In patient with asthma, we give beta 2 stimulant like albuterol or terbutaline. These are beta 2 stimulant drugs, and beta 2 stimulant drug can lead to bronchodilation. Am I clear? So this is one action of beta 2 stimulation on the bronchial smooth muscle. Do you think in bronchial tree or in the lungs there is any other action of beta 2 stimulation? I will be impressed again. Is there any other part of any other component of the lung where there are beta 2 receptors? Of course, there are beta 2 receptors present on bronchial smooth muscles, right? And whenever you stimulate them, there is beta 2 mediated bronchodilation. And clinical point is that beta 2 stimulant are used as bronchodilators like terbutaline, albuterol. They are bronchodilators. And you must also know beta 2 blockers like propranolol, which are beta 1 and beta 2 blocker. When you take propranolol, beta 1 and beta 2 receptors are blocked, and when pulmonary beta 2 receptors are blocked, then beta 2 mediated bronchodilation is lost and there is tendency of bronchoconstriction. That is why propranolol is contraindicated in patients with asthma, because in asthma patient propranolol will block the beta 2 receptors and normal beta 2 mediated bronchodilation is lost. You know, normally our body does have some circulating epinephrine and some norepinephrine which comes from the nerve endings, and this endogenous normal usual amount of adrenergic drive keep bronchi a little bit dilated. So as soon as you take propranolol, beta 2 mediated bronchodilation will be lost. In normal person it may not be significant problem, but a person who has tendency for asthma, he may precipitate severe bronchoconstriction. I was asking that is there any other component of the lung which has beta 2 receptors which may help in allergic asthma? Yes. Mast cells. You know, there's something called mast cells which play a big role in allergic asthma. Mast cells have many types of receptors, including the beta 2 receptors, mast cells. They also have beta 2 adrenergic receptors. And when these receptors are stimulated, mast cell membranes are inhibited, and membranes of mast cell and granules of mast cell is stabilized. So tendency of mast cell membrane to produce prostaglandins and leukotrienes is reduced, and tendency of mast cell granule to release histamine is reduced. Is it good for patient with allergic asthma or bad? My God, it is good. If I have allergic asthma, do you think my mast cell should be stimulated and release prostaglandins and leukotrienes and histamine? You don't want. Let mast cells sleep like dogs. We want them to be inhibited. Is that right? So this is the added advantage of beta 2 drugs, which are beta 2 stimulant, that not only they produce bronchodilation, which is the major action of beta 2 drugs in asthma, but beta 2 receptors on the mast cells are also stimulated, and beta 2 receptor, when they are stimulated on the mast cell, they inhibit the activity of mast cells. So mast cell chemical mediators are not released. So we can say that beta 2 stimulant drugs like terbutaline, albuterol, such drugs not only produce bronchodilation, but they also stabilize the mast cells in the bronchial mucosa. Am I right? Clear? Okay. So this was beta 2 action on the bronchial smooth muscle. Then there are beta 2 action on the vascular smooth muscles. I told you in previous lectures that the blood vessels which go to the skin, they are having alpha 1 receptors. Blood vessels which are going to GIT, they are also having mainly alpha 1 adrenergic receptors. And blood vessels which are going to the kidney, they are also having alpha 1 receptors. But blood vessels which are going to the muscles, they are having more beta 2 receptors and less alpha 1 receptors. Blood vessels which are going to the skeletal muscle, they are those blood vessels. Suppose I remove one smooth muscle here. This is smooth muscle from the blood vessel of skeletal muscle. It has more beta 2 receptors. These are all beta 2 receptors and very little alpha 1 receptors. Right? So when you give a drug which is mainly beta 2 stimulant, then beta 2 receptors will be stimulated and there will be beta 2 mediated relaxation of vascular smooth muscle, in the blood vessels going to skeletal muscles especially. So skeletal muscles, blood vessels will, arterioles will relax, right? And resistance, peripheral resistance to skeletal muscle will be reduced. Now listen carefully. A drug which is purely alpha 1 stimulant, right, that will act on these alpha 1 receptors and produce vasoconstriction. And another drug which is mainly beta 2 stimulant will produce beta 2, yes, that will produce beta 2 stimulation on these smooth muscles and relax. So it means that drugs which are alpha 1 stimulant, they produce arterioconstriction, and which are beta 2 stimulant drugs, they produce here arteriolodilation. It means that alpha 1 stimulant produce increased total peripheral resistance, and beta 2 stimulant decrease total peripheral resistance. Is that right? Now you may be thinking, what is the clinical importance of this? Let me tell you. Right now, I was telling you that endogenously, normally there is some degree of epinephrine circulating in our blood. That epinephrine, endogenous normal epinephrine, produces a slight vasoconstriction in alpha 1 mediated arterioconstriction in cutaneous, splanchnic and renal circulation. And normally endogenously circulating epinephrine normally produces beta 2 mediated vasodilation in skeletal muscles. Is that right? And let me tell you something interesting now. Even though when we read medical literature, we say cutaneous blood vessels have which receptors? Alpha 1. But to be very critical, cutaneous blood vessel smooth muscle has lot of alpha 1, lot of alpha 1, alpha 1, alpha 1, alpha 1, alpha 1 receptor, and little beta 2 also. To be very critical, there are some people who are really nasty and very critical. To be very critical, most of the places in our bodies have alpha 1 and beta 2 both. But when I say that this area has alpha 1 receptors mainly, I mean alpha 1 are abundant, far more in concentration than beta 2. Right? Now listen. There is some clinical importance. When you give a drug which is beta 2 blocker, beta 1 and beta 2 blocker drug is propranolol. Propranolol is beta 1 and beta 2 blocker. When you give propranolol, that will block the beta 2 mediated vasodilation to skeletal muscles. Are you understanding me? When these beta 2 receptors are blocked here, do you think when you do exercise and produce epinephrine and norepinephrine, and this epinephrine goes and through beta 2 mediated action, exercise induced epinephrine through beta 2 mediated action dilate the blood vessels to skeletal muscle. But if you are on propranolol, during physical exertion, beta 2 mediated vasodilation of blood vessels going to skeletal muscles is lost. If you are taken propranolol, beta 2 receptors here are blocked, then when you do physical exertion, beta 2 mediated vasodilation of skeletal muscles is blocked, lost. So there is reduced tolerance to physical exertion when you are on propranolol. There is reduced tolerance to physical exertion. Patient complains of fatigability. He does a little activity and feels more fatigued due to some central action of the drug and due to loss of beta 2 mediated vasodilation in the skeletal muscles. Another thing. Could you understand it or not? You could not understand. Okay, let's start with the basic. Normally we have epinephrine circulating. Normally that act on the beta 2 receptors on skeletal muscles, blood vessels. Normally epinephrine, endogenous epinephrine keep the skeletal muscles vessels slightly dilated due to beta 2 mediated action. Is that right? So we say that in a normal person there is some degree of beta 2 mediated vasodilatation to skeletal muscle. Is that right? And when you do exercise, you get inhibited or stimulated. Your sympathetic nervous system gets stimulated during exercise. You are excited usually, right? When you do exercise, the level of epinephrine and norepinephrine is more in the blood, especially epinephrine, which is released by adrenal medulla. This circulating epinephrine during exercise, right, act on the beta 2 adrenergic receptors on skeletal muscles blood vessel and produce beta 2 mediated dilation. So that increases blood flow to the skeletal muscle. So during exercise, skeletal muscles blood flow increase, number one due to beta 2 mediated vasodilatation, plus during exercise, skeletal muscle produce local factor which dilate the skeletal muscles blood vessel, right? Now you imagine you have taken propranolol. Propranolol block beta 1 receptor as well as beta 2 receptors. Is that right? Because when you have taken propranolol, beta 2 receptors are blocked on the skeletal muscles blood vessels, then yes, beta 2, you have loss of beta 2 mediated what? Vasodilation to skeletal muscles. So when you will do exercise while you are on propranolol, do you think these blood vessels will dilate significantly? No. You will get tired easily. There are multiple reasons. When patients are on propranolol, they feel very fatigued with little exertion. There are some central action I will discuss later, plus this is one action. Another point which is clinically relevant, that our skeletal, these blood vessels which are going to the skin and going to the distal part of the limbs, these blood vessels have more alpha 1 receptors and less beta 2 receptor. Now listen, have you heard of a disease called Raynaud disease or Raynaud's phenomenon? Raynaud, R-A-Y, Raynaud's disease. Actually, you have never heard of things like this. Okay, you will hear. Right now, I'll tell you something. In Raynaud's disease, there is increased tendency of vasospasticity of distal blood vessels. Our distal blood vessels are having increased tendency to undergo vasoconstriction whenever skin is exposed to the cold. Normally when you are exposed to the cold temperature, when you are exposed to the cold, normally your blood vessels constrict. But in some people who are suffering with Raynaud's problem, when they are exposed to the cold, skin distal blood vessels in the limbs constrict so severely that they develop severe cyanosis and even sometimes necrosis of fingers and severe Raynaud's disease. Is that right? In these patients who have a high tendency of vasoconstriction in the limb blood vessels, if you give them propranolol, a little beta 2 mediated vasodilation is also lost. You are understanding? So propranolol will be contraindicated in the patients with peripheral blood vessel disease like Raynaud's disease, because they are already having a tendency of vasoconstriction. At the top you give the propranolol and then there is loss of beta 2 mediated vasodilation and more severe constriction. Is that right? And so how many points about beta 2 receptors I was talking? Propranolol should not be given in a patient with asthma because beta 2 mediated bronchodilation will be lost. Propranolol should not be given to the patients with Raynaud's disease, peripheral vascular disease, because beta 2 mediated vasodilation will be lost. Am I clear? Then, beta 2 actions, and the beta 2 actions which we have learned up to now. Yeah, there is another smooth muscle which is also having beta 2 receptors. Up to now we have said beta 2 receptors are present abundantly on bronchial smooth muscle. Beta 2 receptors are present abundantly on the vascular smooth muscle, and beta 2 receptors are present also on the myometrium of pregnant uterus. We mentioned previously that in the uterus, right, in the myometrium of the uterus there are beta 2 receptors also, and beta 2 stimulation lead to, yes, if you give a drug which is beta 2 stimulant, what it will do? It will produce dilation of what? Uterus dilatation. Drug is not Hagar's dilator. We don't use the term uterus dilation. That is what I'm going to say. Right? If even theoretically or practically, even you are right that when you give us beta 2 stimulant, as bronchioles will dilate, uterus will also relax is a better term. right? We don't say uterus is constricting and uterus is dilating. I don't know why, but this is what they say, right? So beta 2 mediated myometrial relaxation is achieved when you give beta 2 stimulant. And I told you previously, this has clinical importance, that when uterus start contracting, a pregnant uterus start contracting before time, there's premature labor pains and labor contractions, right, premature, and it threatens to produce premature birth of the baby. You can give beta 2 stimulant drug, which will produce relaxation of the myometrium so that uterus should not threat to push the baby out before time. Am I right? What is this action called? If a drug produces relaxation of the uterus, this action of the drug has given a very specific name in medical literature. Someone who has done gynae-ob. Yes? Yeah? Pardon? Detergent? I'm saying if I give a drug to a female and that drug acts on the myometrial smooth muscle and relaxes them, right? So drug action is called tocolysis. This action is called in medical literature tocolysis or tocolytic drug. Doctors have a special tocolytic drug, Rytodrine, albuterol or terbutaline or Rytodrine. These are all beta 2 stimulant. Rytodrine specially stimulates the beta 2 receptors on uterus, right? So what are the typical beta 2 action? Bronchodilation, vasodilation, especially to the skeletal muscles, beta 2 action. There is relaxation of myometrium, of course only in the females, right? Then, no, I should tell you the basic information, right? So then, any other beta 2 actions? Any other beta 2 action? Beta 2 receptors are present on the liver, metabolic action. Oh my God, there is something called liver, which has hepatocyte. There are also beta 2 receptors, adrenergic receptors of course, on the hepatocyte. You must be knowing that when you are under stress, epinephrine is released in the blood from adrenal medulla. Epinephrine will bind with the beta 2 receptors on the what? Hepatocyte, and that will give signal for breakdown of glycogen. Glycogen will break down into glucose and glucose will come out into blood. Am I clear? Glycogenolysis. So there is beta 2 mediated glycogenolysis on the hepatocytes. Is that right? Release of glucose. Do you think this thing has any importance, this information? Yes. There's physiological importance as well as pharmacological importance. Physiological importance is that when you are under stress, as I told you, there was a big black dog after Mr. Gavin. That very moment, a lot of epinephrine come into blood. Epinephrine act on the hepatocytes through beta 2 receptors and do glycogenolysis and release a lot of glucose into his blood. So that glucose can be used by muscles and by the brain to fly away appropriately from the threat, right? It has pharmacological importance that you must know. There are beta 2 receptors on the liver cells. You know, very commonly used drug is propranolol. And if propranolol blocks, what is this funny thing? Beta 2 receptors. What will happen? The liver loses the capacity. Liver loses the capacity to release glucose by glycogenolysis when you have hypoglycemia. Now let me tell you another thing. Whenever you have hypoglycemia, listen carefully. Let's suppose due to any reason I get severe hypoglycemia. Hypoglycemia stimulates sympathetic nervous system strongly. Severe hypoglycemia. And sympathetic nervous system, number one, produces the signs of warning signs of hypoglycemia. What are the warning signs of hypoglycemia? Sympathetic overflow. Sympathetic overflow produces sweating, anxious look, In hypoglycemia, you become irritable and anxious. And in hypoglycemia, when there's oversympathetic flow, you develop tachycardia, palpitations, and when sympathetic overflow, tremors. Is that right? These are the warning signs, especially the patients who are diabetic patients, especially those diabetic patients who are insulin dependent. Listen carefully with both ears. The patients who are insulin dependent diabetic patients, they have a high risk to undergo hypoglycemic attack, because if I'm a patient who is insulin dependent, sometimes I may not take food and take insulin and I develop severe hypoglycemia, or sometimes I take insulin and food in normal amount but do some lot of physical exercise, I will develop hypoglycemia. So the patient who are insulin dependent diabetics, they have high risk of developing episodes of hypoglycemia. When they develop severe hypoglycemia, because they are taking insulin injections, and if insulin is more and glucose in the blood is less by mistake, hypoglycemia is precipitated. What happens to these patients? When brain has less glucose, sympathetic overflow, these patients develop sweating, a strange look which their relatives become very familiar. They develop some anxious and some strange type of looks, tremors and palpitation. Is that right? These are the warning signs of diabetic patient on insulin dependence. And what should we do? We should give them a lump of sugar to abort hypoglycemia. But liver also help a lot, because when due to hypoglycemia there's severe sympathetic overflow, epinephrine goes to liver, stimulate the beta 2 receptors, and beta 2 mediated, yes, glycogenolysis occur and glucose come into blood, so that hypoglycemia does not become more worse. Am I clear? You are not clear about it. You are clear? Yes, you are clear about it, that patients who are insulin dependent diabetics, they have high risk of hypoglycemic attack. During the hypoglycemic attack, they develop anxious look, palpitations, tremors and sweating, right? All these sympathetic overflow feature. With that, epinephrine acts on the liver and releases glucose from there, so that hypoglycemia does not get worse. Am I clear? Now you imagine patient who is diabetic, insulin dependent, at the top he has some ischemic heart disease or some problem which is very common in diabetic patient, and you are the wise doctor to put him on propranolol. You have to be very careful. You know why? If insulin dependent diabetic patient is on the beta blocker, especially propranolol, whenever he will develop hypoglycemia, he will not develop warning sign, because he will not develop anxiety because beta 1 receptors are blocked. He will not develop palpitation because beta 1 receptors are blocked. He will not develop tremors because beta 2 receptors are blocked. So such patient who is insulin dependent diabetic patient, and you are keeping him also on the propranolol, whenever they undergo hypoglycemic episodes, they don't develop warning sign. They don't know they are having hypoglycemia. At the top, you fail the internal glucose provision mechanism. Propranolol also blocks this receptor. So endogenous release of glucose from liver is also blocked. So they have a risk of undergoing life-threatening hypoglycemic episode. So what did I say? That patient who are diabetic and insulin dependent diabetic, if you give them drugs like propranolol, they will not develop the warning signs of hypoglycemia, so they will not take sugar from outside, and unfortunately these drugs will also block the hepatocyte activity to release the glucose, and endogenous release of glucose from the liver is also not there, and they have a high tendency to undergo life-threatening hypoglycemia. What is the message here? That propranolol drug should be contraindicated in patients on insulin dependent diabetes, because these are very, very important things. If you do these mistakes, you give propranolol to a person with asthma or with the Raynaud's disease or a patient with insulin dependent diabetes, I tell you surely you will have a lot of patient swing you. They will get one asthmatic attack, they will get it managed, but you will not be able to manage those millions of dollars for them, right? And next time, insurance company will be very much wary of you, right? So this is all clinically relevant, that beta 2 mediated drugs are good and bad. Beta 2 stimulant again are used as bronchodilator. Beta 2 stimulant are used as tocolytic drugs. Is that right? But at the same time, you must know that yes, beta 2 blocker can precipitate asthma. Beta 2 blockers can worsen the Raynaud's disease. Beta 2 blocker can worsen the hypoglycemia in patient with diabetes mellitus, which is insulin dependent, right? Then one more thing about this, about the beta 2. There is something about, we should talk about tremors. I told you in last video lectures that there are intrafusal muscle fibers which are having beta 2 receptors, and beta 2 receptor, right, when they are functioning well on the muscles, beta 2 receptors, when they're functioning well, right, they help the muscles to keep their tone properly. For example, if I'm keeping my hand outstretched without tremors, one of the reason is that my intrafusal muscle fibers are working well. But whenever I get anxious, I will develop tremors, because during anxiety, epinephrine will come and overstimulate the beta 2 receptors on skeletal muscle intrafusal fiber. So whenever beta 2 receptors on skeletal muscle fibers are overstimulated, you will develop tremors. Now what is the importance of this? Yes, there is. You give beta 2 stimulant for bronchodilation. One of the side effects is tremor. Is that right? One of the side effects is tremor. Now come on another thing. If someone has undue tremors, there are people who have essential tremor. Essential tremors mean they have tremors essentially all the time. There may not be any clear-cut reason why they have tremors, but they do have tremors. So what will do? They can be treated by propranolol. You can block the beta 2 receptors and tremors will be subsided. Am I clear? So when you will become doctor soon and you will be playing with these drugs, what is the difference in average doctor and a great doctor? The difference is how you use your tools, how wisely or clumsily you use your tools. Your tools are drugs, not illicit drugs. These drugs, right? So let's have a break here.